All right, while we are all getting settled in, just want to introduce myself. I am Dominique George. I am a board member for the Policy Center. Came onto the board last year, so this is my first forum. As many have said, lots of information, lots of learning, but really proud to see all of the work that you all are doing individually and collectively. So thank you on behalf of the board for what you are doing to move things forward. I am pleased to introduce Dr. Christine Crawford, the Associate Medical Director for the National Alliance on Mental Illness. Dr. Crawford is an adult and child psychiatrist based in Boston and is also an assistant professor of psychiatry at Boston University School of Medicine. She's an expert on mental health disparities and socio-cultural issues and is moderating this very important panel on gaps in mental health care for Black and Native populations. Thank you all so much. Look forward to hearing from you all.
Excellent, and thank you. Yes, round of applause. Thank you so much for the introduction. You're absolutely right. This is a very important topic. As already was mentioned in my introduction, I'm a psychiatrist, but only 1% to 2% of psychiatrists in this country are Black. And it's not just on the shoulders of Black and brown mental health professionals in order to close the gaps as it relates to mental health inequities. It is a shared team effort and a shared responsibility of everyone, of all disciplines, of all backgrounds to contribute to addressing this issue. And so I'm really excited that we have this amazing panel of experts from a variety of different backgrounds, because there's a sense of urgency when it comes to addressing maternal mental health problems, thinking about the economic impact, the community impact, and just overall health outcomes. So these experts, they're going to tell us about some of the data so we can better understand the scope of the problem. And we're going to hear from the advocates and, think about some of the community recommendations that are out there. And, there are so many different people in this room, from different industries, from nonprofits, policymakers, philanthropists, a whole bunch of folks. But I hope that you will take some of the information away from this panel, and hopefully it will motivate you and encourage you to contribute to the efforts that it will take to make change and address this issue. So enough from me. Let's hear from our amazing panelists. I'll have each of them say their names and give a brief introduction.
Hi, everyone. I'm Abigail Echohawk. I'm a citizen of the Pawnee Nation of Oklahoma and the Executive Vice President of the Seattle Indian Health Board, a federally qualified health center, and an Indian health care provider funded through the Indian Health Service. I am also the director of the Urban Indian Health Institute, which is the research arm of the Seattle Indian Health Board. We are the nation's only tribal epidemiology center. I am blessed every single day to serve my community as a mother, as a sister, as a daughter, as a granddaughter, as somebody who is here on this earth to contribute to the health and well-being of my people. Every day I walk in the doors of the Seattle Indian Health Board, grateful to serve the 70% of American Indians and Alaska Natives who access our services, and then we serve all others the Native way. And honestly, it's the way all of you deserve to be served also.
Can you hear me? Good morning, everybody. I'm so grateful to be here on day 2 with all of you. My name is Stephany Strahle, and I am a data scientist with the California Pan-Ethnic Health Network. We are a statewide advocacy nonprofit, and we are really dedicated to advancing racial justice and health equity in policy. And we do this by really centering collaboration in our work, and we bring together policymakers, community-based organizations, providers, and health agencies to really center the voices and experiences of our diverse communities across the state in the policymaking process.
Good morning, everyone. Long time no see. My name is Breana. I have jokes. I'm a birth equity fellow with Health Connect One. I am also a 4th-year PhD candidate at Virginia Tech, pursuing something called Translational Biology, Medicine, and Health. Long name, we can talk about it later. My dissertation is focused on perceptions related to Black women's health and wellness, and I rooted my dissertation research in the framework Superwoman schema, as well as Black feminist theory, in order to understand the various perceptions related to health and wellness for Black and African American women within this country.
Good morning. My name is Nelson Dunlap, and I am really super underprepared in comparison to these three phenomenal women. So I'm feeling some type of way about being, on the end of this, but that's okay. I serve as the Vice Dean in the School of Global Health at Meharry Medical College. It's a brand new college. It's a brand new school in Meharry's broader college. It's almost 150 years old. And most of my research and my work is at the intersection between law, health policy, and advocacy, all kind of wrapped into the advancement of health equity. So very much excited about this conversation, excited about kind of speaking to the choir and reminding you guys about why what you do is so important and trying to figure out how to keep up with the LOLs from my colleague to my left. So looking forward to it.
Pretty impressive panel, and we haven't even started yet. So amazing. So Nelson, I'm going to start with you. So I'm curious, we have to ground ourselves in the scope of this issue and get a sense of the data and the possible impact. So can you provide an overview of key findings from a report that came out of Meharry?
Yeah, great. So there's actually two reports, and I think they're both linked in your app, or you can just kind of find them online. But one of the sponsors for this event, Otsuka Pharmaceutical, they worked with us on a report that we worked. In my previous job, I was at Morehouse School of Medicine, and we put out a report in 2022 called "The Economic Burden of Mental Health Inequities," and Otsuka helped us with that. And really, that report existed to answer two specific questions. It says, we know that our mental and behavioral health system here in these United States of America, including our territories and the sovereign nations that are here as well, is inequitable, right? And so if we were to make our system more equitable, how many lives could be saved? How many dollars could be saved? The vast majority of my work, as a vice dean, is focused around the notion of the political determinants of health and helping people understand how do we move upstream, right? Like most of us in this room know what those social determinants of health are. And so for every kind of social determinant you could point to, there's a preceding legal, legislative, regulatory, administrative policy decision that led to that, right? And the whole reason for that framework is so that people understand there's power in the work that they do. And so we put this report out to say the system is inequitable. How many lives could we save? How many dollars could we save? So for the folks that are moved by the moral imperative that, spoiler alert, it's 117,000 lives. For those of us who would say 117,000 lives is about 117,000 too many lives, there's information on that. But for others that are more persuaded by that financial imperative, we say it's $278 billion, right? That's how many dollars we're leaving on the table because our system is inequitable. So we put out this report, 2022, the data was coming from 2016 to 2020 because there was kind of like a thing going on around the globe that shut data collection down for a bit, and we were all wearing masks and practicing Safe Six. And so we had the data, and we put it out there, and we told people about it, and they heard it. And then it just stopped being important. Like people stopped focusing. They moved on to other things. So then I got a new job at Meharry, starting a new school of global health. And I said, I was trying to tell y'all stuff and y'all weren't trying to hear it. So I'm going to say it a little bit louder. And so we put out a new report that just came out in May where we're projecting out. And we said, look, we told you before, here's the system. Here's where we are. Here's what we need to do about it. You didn't listen. So now I'm telling you, if we don't get this right by 2040, what's it going to look like? And, I'm just one person. There's an entire team of nerds that work with me. So I make sure to write down kind of the numbers. But, what that highlight of that report says is right now, as a country, we spend somewhere around $477.5 billion annually on inequities with respect to mental and behavioral health. If we don't get this right by 2040, that's 15 years from now? That's just about 4 Olympici, however you pluralize Olympics. Like it's coming very quickly. We're going to be looking at just over $1 trillion. That's how much money we're leaving on the table because of our inequities. And that's the reason that we do what we do. That's why I tell my students, that's why you guys do what you do. It's a reminder for all of you that the work that you do is important and impactful, and there's something for someone, if it's either moral or financial, there's some kind of imperative that says, this is important. You have to keep doing it because it's a way for us to kind of shore up our loins and shore up our economy, as well as protecting everyone's mental and behavioral health.
So given all of that, what do you think are some of the biggest barriers that are faced by Black and Native individuals when it comes to addressing their mental health care?
Yeah, I mean, how much time do we really have? But I would start with just thinking about the impact, right? Like we're here to have a conversation about maternal health and maternal mental health. And this report is on mental health inequities, but there's a maternal component to it as well. And so really what I want to hone in on is that inequity part, right? We're talking about making sure that everyone has the opportunity to, as the young folks say, live their best life, right? For me, it's one of the most important things in the kind of components in the most recent report is with respect to absenteeism. So we looked at, even just the cost for presenteeism and absenteeism, talking about, yes, you're having a mental and behavioral health moment, a crisis, acute, whatever it is, right? And for some folks, they're not able to go to work because of that. That's an absenteeism, right? We understand that. But there's also this notion of presenteeism that is very pervasive in our communities. So as a very quick hypothetical, because I've had the conversation and I'm trying to protect the innocent, you see on the screen that I've got a JD behind my name. That means two things. First and foremost, an incredible amount of student loan debt, right? Just so much. It's just aggressive. But secondly, that means I have an education on being persuasive. And the most important thing that I've ever used that for was to convince my wife to marry me. We've been married 3 years now. And the reason I say that is because now we're at a place where we had those awkward conversations with my in-laws where they're like, you guys trying? I'm like, yes, father-in-law, you understand what that means. That's a thing. But I highlight that because then I go to work and I'm working with colleagues who have known me for years and they know me and my wife. They know where we are in our kind of journey of life. And I've got colleagues that are older and younger and some of them have kids. We go places and they start to talk about their kids and how bad their kids are and all these things. And then they turn to me and they say, Nelson, I can't wait for you to have kids so you can experience that. But I have a relationship with other colleagues who are in their own journey. And so I know there's a young lady that I work with who's unable to have kids currently, right? And so every time we have that conversation, I cringe because I see what that does to her. I see the look that she has on her face. And then we have to have a conversation afterwards where I'm like, look, I know that I'm usually kind of not the greatest guy, but I'm sorry for that. I didn't start that. I want you to know that, I wish we didn't have to have that conversation. But then she's got to turn around and continue to do work. She's still at work and she's still dealing with the realities of everything that's happening outside of work. Everything that's happening as a Black woman who's struggling with this, who then may become pregnant and have higher incidences of all the other things that we talk about. That's absenteeism, and that's presenteeism. She's there, but she's still dealing with it, right?
And that's a great example because you're seeing this firsthand, at all levels. And so I want to turn it over to Stephany. In a similar way, you're joining us from the California Pan-Ethnic Health Network. So what insight can you share from CFEN's report on improving care for those with serious mental illness?
Yeah, so we published 2 reports in December at the same time.
And this is important, so we want to hear you. Put the mic right here.
Sorry. Okay. Let me know if you can't hear me, put a hand up or something. So the first report I think they pair really well together because the first report has kind of that quantitative data analysis piece, and we're looking at mental health outcomes among Medi-Cal members, which is our state's Medicaid program. And then the second report has more of that community lens and what are community-based organizations across the state doing to implement what is known as community-defined evidence practices, or CDEPs. And going back to the first report, so what we saw was that our Black Medi-Cal members were having lower rates of accessing preventative care, but the highest rates of seeking care for serious mental illness. And then on top of that, although utilization overall was generally low across all groups, in diagnoses, we saw that Black Medi-Cal members were getting diagnosed at higher prevalences with schizoaffective disorders and schizophrenia. And so that brings me to say it's not that people are avoiding early mental health care, it's that they are often shut out of these systems, and that can be due to a lack of culturally competent care, inadequate outreach, and then a lack of community-based prevention, which really prevents that earlier care and forces people to seek care only when their condition worsens. And then so going to the second report, we focus on findings from an advisory group we put together of 8 community-based organizations across the state, and a lot of them are working at the intersections of housing, immigration, communities impacted by incarceration, and then gender violence. So you can see a lot of the social determinants within that. But from them, we saw, several challenges and several policy recommendations come out of it. But I think at the core of it, what we saw was that a lot of the solutions we need to improve access for mental health care in communities is already out there. And they are community designed, community led, but not properly funded. And a lot of CBOs, they're navigating really complex billing systems. And on top of that, having to put together like a patchwork of short-term grant funding to sustain their practices. And in the long term, that just doesn't work out. And then I think like another challenge that people were bringing up too is that like these sites of clinical and institutional care are not designed around the community experiences and the unique needs that people need. And then I want to just...
And I want to talk about the community needs because that is so important. And I appreciate the context that both you and Nelson provided. But I want to turn now to Abigail and Breana to learn a little bit more about what is happening within these communities. And so, Abigail, I know that you've led some incredible research around the systemic and historical factors that shape mental health disparities for Native populations. So can you discuss the historical trauma and how that might affect mental health, especially maternal mental health?
I love sitting on the stage with data people because I'm a data person, directing epidemiology. I always say I'm a data nerd. And one of the biggest issues with the data, which is one of the reasons anytime Nelson or others who are working to ensure inclusive data ask me, I'm there. Because one of the biggest problems is this nation is eliminating American Indians and Alaska Natives through the data. It is something my organization has termed to be data genocide. Who here knew that the American Indian Alaska Native population has a prepaid benefit for quality physician-led healthcare? I'm seeing like 3 hands. I don't know about y'all online, but you need to learn about that. That is what our treaties are. If you live in the United States and if you're in this room or you're viewing virtually, the land that you are on in our treaties was a part of the prepaid, we paying for this benefit for healthcare that we are not receiving. And when we are fighting for that healthcare right, whether it be in Congress or at the state level, we are dependent on data. And the data is what says, okay, if you have this many tribal people, then Congress allocate this many dollars. Not saying they actually do it. The Indian healthcare system is chronically underfunded. When we talk about historical trauma, we often talk about it as ending 50 years ago, 100 years ago. Y'all, this is historical trauma for me right now. My people are dying. I walk into a clinic every single day where I see people who have been assaulted on the street, where I see relatives who are happy and thriving with their children. I see elders who have no home to go to, so I hand them a tent as they go back out on the street. That's not the prepaid benefit. So when we talk about inclusive data, make sure that you are including American Indians and Alaska Natives, because if I have to look at another report that says I am statistically insignificant, let me talk to you about how my community has never been insignificant. And in fact, all of you all benefit from what my community has thrived with. And so we need to make key investments. And we have some incredible folks right now congressionally. Senator Lisa Murkowski continues to be a strong advocate for Native maternal health generally. We have strong folks in the House. Representative Simpson from Idaho has been consistently fighting for the full funding of the Indian Health Service. Because somebody like me walked in the doors as a teenager to the Seattle Indian Health Board, where I now serve as the executive vice president. I was pregnant, I was in my 2nd trimester, and I had not received care because my very first visit I ever gone to was at a large hospital system. When they saw my last name, they saw that I was Native. The woman pulled back my sleeve and took a look and accused me of using drugs and of drinking alcohol. She refused to believe I hadn't done it. I don't even remember what happened when the OBGYN walked in the door. I don't remember that visit. All I remember is they're going to kill me and they're going to kill my baby. And it wasn't until I walked in the doors of the Seattle Indian Health Board, a culturally attuned provider in our community, serving our community the right way, that my mental health was protected, my physical health was protected, and my cultural, spiritual health thrived in that community. And that is the change we need to be.
And I can see how emotional you're getting talking about this, because this is real, you know? And you're right about how it's impacting your community. And I really appreciate how you just let us know. And I'm sure it resonated with everyone in this room. So thank you. Thank you so much. Breana, I want to turn over to you. You know, you talk a lot about and work a lot with the community and looking at community-led systems and looking at how the community can help with addressing maternal mental health disparities. So can you talk a little bit about that work that you're involved in?
Yeah, so if you don't mind, I want to frame it from the perspective of Black women and superwoman schema and things like that. And I also want to acknowledge that it took a lot of bravery and vulnerability to share that, and it's really freeing. So thank you so much for sharing that as well. So I'm a Zillennial. I'm chronically online. I love the Clock app, aka TikTok, and something recently popped up where there are these two Black women sitting in the car, and they were outside their friend's house. She just had a baby, and they were singing Beyonce with the windows rolled down to Girl. And they were trying to tell her, like, you don't have to be happy, like the lyrics, I'm not gonna sing, but we're here for you. And that was so significant for a variety of reasons. And just thinking about this, as my colleague said, Nelson, you can talk about this for forever, and I can't belabor the point because we're going to run out of time. But when thinking about just mental health in general in the Black community, that is not something that's talked about for a variety of reasons, and it's extremely nuanced. Just from my own research with my dissertation, we're finding that within the Gen X and older generation, that it was a very like prayed away mentality. What happens in the household stays in the household. You need to talk to Jesus. That person has demons. They're not well in the head, things like that. But mental health is not a scarlet letter. It's not a character flaw. It doesn't mean that something's wrong with you. And on top of that, you're allowed to pray to Jesus and seek mental help. You can pray to Jesus and get medicated. You can pray to Jesus, be a Christian, and still realize or recognize that there is a chemical imbalance, and that does not mean that something is wrong with you. And after having a baby, even though I'm not a mom, we know that there's hormones are going crazy, right? And it makes sense. You just brought life into this world. Hormones were going crazy to make this life. And so with that, coupling the fact that we already don't talk about mental health as a culture, plus postpartum, it is just a crazy cascading effect. And like I said, I want to root this in superwoman schema. So a couple of things that really stuck out to me about the frameworks with that is that there's an obligation to suppress emotion. There's an obligation to present an image of strength, and there's a resistance to being vulnerable or dependent on others. Therefore, talking about mental health culturally within the Black community is very, very difficult, and it's very, very nuanced for so many cultural as well as historical implications. So like multiple things can be true at once. We need to be in community with one another and being able to share and be vulnerable like Abigail. We also need providers that are able to recognize those various cultural nuances, as well as have programs and organizations that don't have an all is welcome mentality, but have a we built this with you in mind, meaning they understand superwoman schema. They understand Black feminist theory. They understand various Black, brown, and indigenous frameworks that are going to facilitate this overall cultural shift and change, not only for Black and African American women, but for Native, for brown, and other women of color.
You're definitely a superwoman. Everything that you're sharing is amazing, and amen to that. Amen. So I want to make sure we have time to now focus on solutions. What are things that stakeholders can do? And we're just going to go down the line, just a couple of minutes each, about what your organizations are doing to address some of these issues. So Nelson, we'll start with you, minute or so, and we'll go down the line.
Again, it's kind of rude that I have to go first, but that's okay. I would say actually two things. First and foremost, it's a reminder that at the School of Global Health, our motto is we, not me. I want our students to always remember that the work that they're doing, it's bigger than them. It's about we, not me. When we talk about mental health equity is all about we, not me. The reason that you guys are here is that reminder that the work that you're doing is bigger than you. It's more than just yourself and just your own community, your own family. It's about the work that you're doing that impacts everyone. Keep that in mind. I think that how that comes to fruition for us is every time we put out one of these reports, we might make sure that we have a national advisory panel. So as Abigail was saying, I work in HBCU, historically Black college or university. I can talk about the issues that are facing Black communities until I'm blacker in the face. I can do that. I've got the research. There's plenty of folks who look like me down the halls that do that. But this doesn't just impact me. It impacts all of us. So making sure that there's a representative, make sure that there's someone there who can speak about the lived experiences, that understand what's happening in sovereign nations like Abigail and all the other boxes that we'd like to put people in is important. So that what I will say is reach out to folks who don't look like you, who don't have the same lived experiences, and make sure that coalition comes together, because we're in a fight and we need as many hands on deck as possible.
All hands on deck, that's for sure. Abigail.
Right now, there's an opportunity. Secretary Kennedy is very interested in chronic disease prevention. And one of the things that we fought for in the previous administration is billing for traditional indigenous medicine. We managed to get that through CMS, and now there's opportunity both at the congressional level and at the CMS level. I ask that all of you advocate for that you look at 1115 waivers, traditional Indian medicine, and what we can do to fight for that. The other thing is if you are coming from philanthropy, there is nothing wrong, and in fact, you should be actively look at how you are making strategic investments in the lives of Black and Indigenous women and people who birth. That is an ethical imperative that you are focusing. Our health is your health. If we are not healthy, neither are you. And so making those strategic investments are important. As the one and only Queen said, Beyonce, we will find healing where none lived. And the only way we will do that is together.
Man, we're quoting Beyonce now. I'm loving it, loving it. Stephany, 2 minutes, 1 minute, 1.5. Go ahead.
I think first and foremost, just we need to be really intentional about how we partner with community-based organizations, making sure that they are the ones leading the charge and that we bring prevention back into communities and just help people feel less alone, because CHWs, community health workers, and peer support specialists, they are people with lived experience that can offer that unique perspective to help people feel confident to seek the care that they need.
I feel like I already used my best material, but like I said before, there's a difference between an all is welcome mentality, and we built this with you in mind. And so continuously evaluating the framework that exists and continues to persist for Black, Brown, and Indigenous birthing people, women of color, is going to be imperative to making sure that we fit the needs of the community, continuously making sure that we are equipping these community-based doulas with the proper tools and framework to do their job to the best of their ability, because this is a cyclical work. There's always more work to be done, but if we don't have the proper tools, then we will never be able to dismantle a system, and we'll never be able to lead to forward progress.
Fantastic. I mean, we need to triple the time to really dive into this. I mean, amazing, amazing, amazing. And each of them should have their own talk. Honestly, I would sign up for that. I just wanted to hear more and more, but here it is. You've heard all the data from the experts, and the collective power in this room. We are able to make a difference. I know when it comes to mental health inequities, it just feels sometimes that it's hopeless. But you can see here on this stage that there are people working hard each and every day, and hopefully that will encourage you to join in on the efforts as well. Because again, it can't just be on the shoulder of us 5 people. It has to be everyone who's dedicated and passionate about all of this. So I just want to thank you for featuring this amazing panel.